So we're here today to discuss Isthmic Spondylolisthesis. On my right is Dr. Rick Placide, Dr. Michael Suer on my left. I'm Evan Johnson, a physical therapist at Columbia University Medical Center and Neuropresbyterian Ox Spine. Dr. Placide, would you introduce yourself, please?
Yeah, Rick Placide. I'm a professor of orthopedic surgery at Medical College of Virginia in Richmond.
And Dr. Suer?
Yeah, I'm Michael Suer, assistant professor, background in physical medicine and rehabilitation, and then a pain fellowship, all at the University of Wisconsin.
In discussing the topic in preparation for the video today, we discussed should we limit it by age. We commonly see isthmic spondylolisthesis with a lysis often in the younger individuals and athletic individuals, and we decided to focus a little bit more on that. So to that end, I'd like to start with the idea of the lysis, the fracture itself. And what do you use from a physical exam perspective? What do you look for in the individual who's presenting with acute onset of low back pain, maybe a teenager or someone in their young 20s? What are you looking for from a physical exam perspective? Dr. Placide, why don't you start?
So the exam should be comprehensive, like any typical examination of a spine patient, orthopedic and neurologic exam. Some of the particular findings, these patients tend to have, and I'll put tight in quotations, tight hamstrings. Some think it's a postural problem, some a neurologic. It may be just related to the paraspinals being tight and in spasm because of the instability around the fracture. There are some other physical exam maneuvers. I think Dr. Suer knows a little bit more about some of those on picking up specifics of the instability.
Yeah, I think initially it starts with just observing the patient, looking at how they're standing. Tight hamstrings can be present, but even in a standing posture, you can have a knees bent, hips flexed. You can have an exaggerated lumbar lordosis with some of these patients. Simply on exam, it is hard to palpate any of these structures to find a specific location of pain. Oftentimes they have very tight lumbar paraspinals. And when we talk about sensitivity and specificity of different tests and exam maneuvers, one of the common ones that I will use as they're standing and as I'm looking at their posture is a single leg hyperextension of the low back. So you'll have them stand on their left legs, for instance, and extend backward. And if that reproduces pain, then there's a possibility of a pars fracture on that side. You would do that on the contralateral side. If they're having bilateral, you obviously want to do it on both sides. Unilateral pain, I typically start that on the unaffected side so that they can at least get the motion down before they go to the more painful side. Evan?
Yeah, I think that's a useful exam, Dr. Suer. I do the same. I'll often balance the patient. I think it's important too, so they go into full extension, because if you stop short of full extension, you're not getting loading of the unilateral posterior column to the same extent. I'll even occasionally add a little bit of unilateral rotation to really load that facet on that side and through the posterior column.
And I think one thing we should mention is that we look at the mechanism of injury in a lot of these young athletes. It has to do with hyperextension. And if you look at the common sports, particularly gymnastics, or another subset of individuals with hypermobility, whether this is Ehlers-Danlos or more benign hypermobility, looking purely at extension, some of them can extend quite far beyond what their age-matched norms would be. So just because someone gets to an age-matched norm for what extension should be, doesn't mean they're at their normal extension in the lumbar spine.
It's interesting. I also see it in weightlifters. I see a number of ball players, particularly baseball players, but often in weightlifters, jerk press or squats, when they fall into more lordosis or lumbar extension as they're doing the squat. Dr. Placide, I guess first, what population are you suspicious of as they come in? Mm-hmm. And what are you suspicious of in terms of presenting characteristics? And then from a radiology perspective or an imaging perspective, right, what are you likely to order up front as you explore the possibility of listhesis?
So when we see the patient, you do consider the history. Typically, this is a condition of someone after age 10. It's extremely rare in anyone below age 5. It's only ever been reported in ambulatory humans. So, for example, somebody with a bad spina bifida occulta and they're born paralyzed, that has never been demonstrated, this pars defect to be found. So the history is important because this is much more common in athletes, as you guys have just mentioned, particular athletes. If the general population of this pars defect occurs in about 6 to 8% of patients, and some of these gymnasts and these lot of aggressive athletes, it can be over 20% of them will have a pars defect. So the history is important coming in. The physical exam maneuvers that you just described. Also, once the pars defect, which is the lysis, so the bone is fractured, the pars intra-articularis, most commonly at L5, once the vertebra starts to slip and translate, so now you have a spondylolisthesis, you can actually palpate a bump or a step off because the posterior elements from the pars fracture, the lamina and spinous process, stay posterior as its vertebral body translates anteriorly. So you'll feel that as a bump of the spinous process of L5, where then it dips into L4. And then when it comes to the exam, and then we discuss imaging, plain radiographs are an easy way to start. I typically do AP and lateral and a flexion extension view. Yep.
To that end, Dr. Suer, what would spur you or move you towards getting a oblique view? Why would you get one view versus another in this population? And why would you go past plain imaging? Maybe you have a plain image that's patient doesn't have a significant slip, but they are developing a lysis, which is invisible on the immediate X-ray or post-injury X-ray. What would you do next?
So I think that's a good question, because there is a lot of debate on imaging, at least initial imaging of a lot of these especially athletes. Some indicate you should only image after 2 to 4 weeks of rest to see if there's elimination of a muscular strain. Often people advocate for AP and lateral alone. And arguments there would be that oftentimes the lysis will show, and you're having less radiation exposure. Now, you could get an oblique view, which is the Scotty dog view that a lot of us know and are very familiar with. However, X-rays are not 100% definitive for demonstrating that fracture. I think there's two components when it comes to, am I going to get advanced imaging? And specifically talking about an MRI or a CT scan. SPECT scans are also an option. I don't routinely do those. But for me, the one part of this is that we're oftentimes dealing with athletes. We're dealing with parents. Along with that, there's some anxiety. There's wanting to know what's going on. I often, to be honest, don't put a large roadblock into saying, we technically should not get an MRI for another 4 to 6 weeks, because you're helping the patient understand what's going on. You're getting better buy-in if you can demonstrate a fracture for your treatment plan, which is oftentimes a lot of rest. And so getting young, high energy athletic individuals to rest can be hard. Sometimes an MRI will help do that. Now, an MRI, the perks there is that if there's an acute fracture, you will see some edema in the bone or in the surrounding tissues. A CT scan would be better at actually delineating the fracture, but it will not as well demonstrate acute versus chronic because of the edema that's going to show up on the MRI. So honestly, I have a fairly low threshold for ordering an MRI in order to better understand the diagnosis, help the patients understand the diagnosis, and have my treatment plan be closely followed to then get longer term improved outcomes.
Is that similar to your process or your thinking process?
I would agree because other things cause back pain too, and the MRI is going to be the better test to help with the differential diagnosis.
I'd like to take it a step further, which then will also lead into treatment. Diagnostic injections, right, which then may quickly lead into injections as treatment or procedures as treatment. If you're looking for a diagnosis, maybe you see that there's a lysis, maybe there's a small listhesis, a grade 1 listhesis, and you want to know, is this a source of pain in the patient who has, whatever, 2 or 3 other things going on in their spine? What's your protocol, or what's your thinking in that regard from a diagnostic injection perspective?
So if a patient presents with predominant back pain, that's ipsilateral to the side of their pars fracture, or bilateral, assuming they have bilateral fractures, injections can be used. Now, you do need to be very careful if you're injecting a steroid, which I typically do not do, into an acute fracture. If we want to answer the question of, is this pars fracture the cause of pain? I would view that as a diagnostic injection, similar to how I would view a medial branch block if we're going toward a radiofrequency for lumbar facet arthropathy. Those injections, typically I oblique to find that Scotty dog view, identify the pars fracture. Local anesthetic goes into that pars fracture, and usually a very small amount on the range of 0.5 mLs of either 2% lidocaine or 0.5% marcaine that goes into there. And then we have the patients track their pain. We're just injecting a local anesthetic to diagnose this as the cause of pain. So we often have them track it every 15 minutes for an hour, every hour for 8 hours, and then call our clinic the next day to let us know how they did, both from a pain standpoint as well as a function standpoint.
Dr. Placide, from your perspective, what's the bar to start seriously considering surgical intervention? Right? What are you looking for? I imagine progressive neurologic deficit, obviously, if the slip was so great.
Sure.
But, so that, and beyond that, what are you looking for as indications for considering surgery, having that discussion?
Well, the majority of the adolescents with this will get better with time. And when I say time, it can be up to a year. Even without the fracture healing, they can improve. So it's an aggressive attempt to not operate, in my opinion. But there are those that intractable pain have a positive diagnostic block that's their pain generator. They can't get back to their sport or their activities of daily living. Again, as we mentioned, most of these are in high-level athletic competition, so they do want to get back to that. The neurology is would be rare, can happen with very high-grade slips. But if you had dynamic radiographs showing instability between flexion and extension, that would probably push me a little bit more to stabilize it. When you have just a pars defect without the spondylolisthesis, without a slip, you can do a pars repair. You don't have to fuse one level to the next. And there's a variety of techniques of doing that, and they do well. Once the vertebra starts slipping, and we'll use the example of an L5 on S1 because that's the most common, you end up with an L5 to S1 fusion.
So I'd like to pull the conversation back a little bit to my area of clinical practice, and that is from a physical therapy perspective, which I think you both agree is kind of first-line treatment. How do we treat this, or how would I go about treating it? And I think one of the things I see in practice is decreased activity without sensitivity to what is some of the more provocative postures, just decreasing activity across the board, right? So, and maybe the kid decreases activity or the young individual decreases activity, but still lugs around a backpack with 20 pounds or 25 pounds of textbooks in the backpack across one arm as they go through school or all day. So part of what I've found is while avoiding heavy loads to the posterior column, you actually can work fairly intensely, these individuals, as long as you avoid extension and heavy axial loads. And so it gives them the opportunity to still work quite a bit, whether it's cycling or upper body ergometer or lumbar space stabilization type activity. Sometimes you will see, getting back to your point about the lumbar paraspinals, if you put them in a plank position and they get a lot of activity of lumbar paraspinals, sometimes that compresses the area. And if they're still hot or in an acute stage, that may be more than their body can take. But I do think one of the signs that I look for, and I imagine both of you as well, and that is if they do an activity and they show increased irritation down the line, 45 minutes, an hour and a half, 2 hours later, then I assume that I'm inflaming structures and I'm retarding their progress.
I would agree with that. And I think that reminds me of an idea of bracing. Do we brace these individuals when they have a fracture? And I don't routinely utilize a brace. I think a brace for the patients that I have seen has been useful to help limit extension, help limit hyperextension. So even a corset brace with a lumbar stay can help them avoid those extension maneuvers, but yet stay active.
Yeah, I would agree. I think the bracing can help with the pain and aggravating an inflamed area, but it's shown that it doesn't change the actual healing rate of the pars defect over time.
Interesting. And then, of course, I think we all, or I certainly work on saying, how do we create your existing core musculature, the deep abdominal muscles and the multifidi in the spine and so forth? How do we use those muscles to accomplish kind of an ideal posture and avoid the postures as much as one is cognizant or aware? To that end, if there's any last comments you have or thoughts, as we wrap this up. Anything you think we omitted here you'd like to bring out?
I would like to mention there are case reports. I don't know that this is actually an on-label, but using external bone growth stimulators. There have been patient reports of hard-to-heal fractures and pars fractures as well, and have them heal. So just another thing to consider.
And you, Dr. Suer?
I think the other part is to focus on the mental health of the athlete. We're pulling an athlete from a sport from a fracture that sounds awfully scary. Focusing on that mental health, whether you have a sports psychologist or a pediatric psychologist available in clinic, would be really useful for them long-term getting back to activities.
I think that's both important points. One thought I have is you both mentioned the tight hamstrings as this kind of protective mechanism. And I would say, that the patient has the right to that protective mechanism, so one doesn't necessarily take it from them. But there's certainly ways to work on flexibility that are benign to the spine. And I think as we look at this, again, it's more prescriptive exercise than generic in this world of kind of YouTube and Instagram exercise. There are ways to be very sensitive and prescriptive relative to the specific pathology at play. And I think it's important we explore that as physical therapists to, as much as possible, avoid a possible surgical consequence or minimize procedural interventions except as needed.
Yeah.
Thank you both.
Thank you.